Okay, bonjour tout le monde. Good morning, everyone. My name is Hélène Buteau, and I'm a member of the Board of Directors of the Ottawa branch of the National Association of Federal Retirees. First, I'd like to begin by recognizing the First Nations on whose traditional lands the Ottawa branch office is located. This is unceded traditional territory of the Algonquin, Anishinaabe people. On behalf of the branch, I'm pleased to welcome you to today's session entitled All About Strokes, Prevention and Rehabilitation. Please welcome our presenter, Dr. Hillel Finestone, who is a specialist in physical medicine and rehabilitation. Dr. Finestone is a professor in the Division of Physical Medicine at the University of Ottawa. He is also the Director of Stroke Rehabilitation Research at the Elisabeth Bruyere Hospital. Today, Dr. Finestone will be talking about what exactly is a stroke, what to do to help prevent one, and how to help rehabilitate yourself if you've suffered one. Thank you for being with us this morning, Dr. Finestone. Veuillez noter que cette session sera présentée en anglais, mais la participation bilingue est toujours encouragée. I want to give a special welcome to anybody here who is not yet a member of the association. We hope that these webinars will inspire you to join us. And to our members, we hope that these webinars will encourage you to maintain your membership. Finally, if you have any questions, please type them in the Q&A box throughout the session. Dr. Finestone will respond to them during the question and answer period at the end of the presentation. That's all now for me, so I'm going to turn over the presentation to Dr. Finestone. Thank you.
Thank you, Hélène. It's a great honor and a privilege to be here today. As we were discussing before, that I think this is a good audience for this topic. And as myself, as our aging, I just try to talk about things that I, as a physician in stroke rehabilitation, do on a day-to-day basis, still to this day, and try to bring you into the office. So we called it stroke. What is it? Can I prevent it? And how can I rehabilitate myself after it already happened? And we're in medicine, and any talk that you give, you have to have objectives, and it's a good idea. So, because it makes you think about what you want to present and what you want the outcome to be in this talk. So at the end of this talk, we want you to be able to understand what having a stroke means. Sounds kind of funny, but actually I've been asking that to pretty much every patient that comes through the doors these days, because I'm finding people don't know, even though they may have been in the hospital for 2 weeks. To learn some of the risk factors of stroke. That's probably one of the most fundamental parts of this talk. Know what it takes to rehabilitate after a stroke. And I'm doing something that I never did before. It's something that I've worked with my patients over the years. And so I'm just going to try it out for fun, see how this memory aid to help us and helps myself, and see how you like it. And it's not published, and it's brand new. It's called Maintenance of Transitions, called sometimes MTL. And so, like I said, I'm going to try to bring you into the office, and we'll use some of the terms that I use. So if I'll say to a person, what is a stroke? I think about 50 to 60% of my patients will know these are patients who've had a stroke. So, but this picture is of a lightning strike, and that's where the word actually comes from. The sudden development of a specific event, weakness. We'll talk about it. But it has to be, and maybe I'll even make this a little easier next time, it has to be something related to the blood flow to the brain. So if someone got a gunshot wound to the head, or hit by a baseball bat, or falls, usually that's a brain injury. It's usually a little bit different. It's not exactly a stroke. And it's a lightning stroke affecting the blood flow in the brain. And just like it could happen so suddenly, like a lightning strike, that one moment things are going okay, and suddenly there's say weakness of the hand or loss of feeling. So it's in medicine also, but I think it's good for all of us. It's an opportunity to go through a case and sort of use the case and talk about it and any questions later on. So is there a typical case? I think saying stroke is like saying cancer almost. It's like saying, because if you have cancer, you could have skin cancer, liver cancer, eye cancer, breast cancer, and each one has different treatments and different outcomes. So there's different kinds of strokes. So this is Mr. Gunug. He's 66 years old. He has high blood pressure. He has type 2 diabetes. And I asked him about cholesterol, and he said it was on the highest side. I didn't think he was treated. He didn't think he had treated it. We asked him about smoking, and he said 5 years ago he had a small heart attack, hasn't really affected him that much, so he quit. His wife notices that he snores, and sometimes he actually stops breathing. So that's a big thing that you should always go in, if you can, with your partner, male, female, because this is a question. If I will ask, do you notice, Sean, that your wife is snoring? Patients don't really know if they snore. And then the question of, does the person actually stop breathing? Because what does this mean? This is the classic thing of sleep apnea. Sleep apnea means that someone stops breathing in the middle of their sleeping, and it's a risk factor for stroke, as we'll talk about in the next few slides. So stopping breathing, it's pretty much, with snoring, you don't really need even a sleep study. That's the best sleep study. The husband or wife saying to the doctor, he stops or she stops breathing and it's snoring before that. And then they often wake up with sort of like a sort of coughing kind of way. And that's clinches it. But still, a sleep study is the way to go. We happen to have them in Ottawa, quite a few, and it's a good test to have. So at 10 o'clock at night, his right hand feels a little tingly. He's brushing his teeth. It falls off. It falls down. He notices when he's walking back to bed, his balance is a little off. His speech is a little slurred. He thinks it's sort of when he was just like saying something from far to his wife. But as it's not uncommon in Ottawa and in Canada and certainly in the world, he didn't really think he had a stroke. Maybe he thought he had a stroke and he was kind of in denial. He says, I'm just going to go to bed and we'll see if I could shake it off in the morning. Not a good idea. So we're going to tell you that you don't do that. If you see and feel, if you see someone or the person you feel as a person, this is the main thing to do, is to get help immediately. So that's where our society has some pretty good care. I know our medical system is in difficult times these days, but still, for stroke care, it's pretty damn good. It's very good. It's probably one of the best in the world. So the next morning, he's not terrible, but he's still shuffling a bit. He's weak on one side. His wife she says, I think you're having a stroke. He called 911. Because it's more than 4 hours, that's the magic kind of time. The hospital says, well, we can't do anything specific. Specific meaning, because they did a CAT scan, and you could see on one part it's a little bit more swollen on one side than the other, because this is pretty fresh. So you could see on one side there's like little rivers and tributaries, but when we're facing this this CAT scan, you look at the right there, you see it's a little sort of filled in. There's not a little bit of those rivulets, and that's because the brain is a little swollen because he had a stroke. Stroke involving one brain territory called the middle cerebral artery. So because it's more than 4 hours, that's why you want to get to the hospital before 4 hours. It's too late to give some intravenous injection, which is quite good, some clot busters, which are called TPA. And now more people are getting another kind of clot buster called TNK. But they do see a little blockage, and this is only really that's done at the civics. That's why everyone gets filtered now pretty much to the civic. they do see a clot that they think maybe is sent a clot or clots there. So this is, I just wanted to give you a little picture of what they're doing these days, in that they could actually take a little needle, put it through your leg, thread it up into your neck, a little higher up, say about this level. And if they see that clot, they could put a little needle through it, or they have suction, and they could remove the blood clot, for instance, using suction, or break it up with other things and different methods. So we said that he didn't go fast enough. And this is something that I made up, because I know, even though not everyone knows, that about fast. This is the key thing that is probably around North America, the world, the science of stroke. So we want you, the audience, to know at least this: fast. And you're going to remember that F stands for face, is drooping. A stands for arms. Can you raise both arms? Is there a weakness? Because one of the things of stroke is that when people put their arms, there's a little weakness, and it sort of drifts down the weaker side. Is the speech either slurred so that you sort of know what they're saying, or is it jumbled that the words don't make sense themselves, or the way the sentence is, it doesn't make any sense? And then fast, F-A-S-T, the time is, it's time to call 911 right away as soon as these symptoms are happening. I've added some other things that we should know, because these are the ones that get missed the most. They don't want to add them to heart and stroke because they feel there's different opinions that maybe the symptoms on the right here, maybe people will go too often to the emergency room, but I think you should know about them. So other important stroke symptoms could be, for instance, vertigo, which means spinning. At people our age and older, 60, 70, 80, inner ear problems, which is a common cause of spinning. It's common, but it's not that common. It's also maybe more common that a stroke could cause spinning, a sensation. And often that could be associated with nausea and vomiting. Now, I know nausea and vomiting, it's kind of common. You get it with infection. You could get it with bad food. But still, if you don't have any of those other things, and you just have kind of isolated, just headache, some spinning, nausea and vomiting, you got to think stroke. You got to think your loved one's having stroke or your friend's having stroke. Double vision, sudden onset of double vision for an older person or any over 50, 60, you got to think stroke. And swallowing troubles, that all of a sudden the person has some swallowing trouble. Now, we know it could be with other things like even Lou Gehrig's disease and other things, but sudden onset of swallowing, double vision, nausea, vomiting, those could be stroke. So that's what I wanted to. So that's something I say in my office. It's not really commonly in the posters because they don't want to have too many symptoms, but now you know. Okay, so how do you get what kinds of strokes are there? So basically, in the biggest way to subdivide them, there's two kinds. One is not enough blood flow, which is called ischemic. That's a blockage, one of the tubes. So you could see in this picture, a little large blood clot in that circle. That's a clot, or maybe, and you see the vessel is full of fat or some other stuff that's called like hardening of the arteries, or also called atherosclerosis. And you finally get a blockage, so that piece of brain is at risk. We used to say that piece of brain maybe died, but now because of these other interventions, these things like the clot busters and the clot taker-outers, that there's a chance to salvage and save some brain. And we see that all the time for people who come within the 4 hours or maximum, say 24 hours. The other kind of stroke is on the right there. It says hemorrhagic, or is also or bleed. So about 20 to 30%. Hemorrhage strokes, cerebral hemorrhage, it says there. And you could see sometimes the vessel will break out open because it's been had too much damage to it from smoking, cholesterol, and other things we'll talk about. And I can't answer that. But and so but sometimes there could be high blood pressure or a big vessel. Sometimes people have abnormally born vessels, unfortunately, and they're weaker and they could bleed too. So there's different reasons for a hemorrhage. So if I had to say, what's the most important slide here? Maybe this is the most important slide. Made this up from scratch because this is what I sort of want to get you to think of how I would say it in my clinic. I'd say, look, stroke is a plumbing problem. You got a house, you got the plumbing going all around it, you got rust in some of the pipes. Sometimes people, for the same reasons, get their sinks blocked up. They get the downstairs sink, the upstairs sink, the faucets. So we don't know why, for instance, smoking, which 100% causes plumbing problem, clogging of the arteries, atherosclerosis on there. We don't know why some people will get a heart attack, which is a clogging up of the arteries to the heart, versus a brain attack, which means a stroke, which is a clogging up of the blood vessels to the heart, versus a black finger, which could happen, which is a clogging up of the blood vessels, versus kidney failure, which a lot of people with need for dialysis and even transplants are often from plumbing problems from stroke risk factors. So let's look at them. What are they? High blood pressure. If it was a smaller group, I'd say, what do you think of that? But it's called the silent killer. That could cause a blockage of the vessels, and you see there, it says progression, formation, growth, and rupture, blood clot. So you get like a thing called plaque, Plaque. Sometimes it's a C, and basically it's the inner lining, which is supposed to be nice and smooth, fills up with junk, with fat, with cholesterol, and starts on a road to blocking. If you're lucky enough, it doesn't. If it stays half full or half not clogged up, chances are you're not going to have a stroke or heart attack. But high blood pressure, which you can't measure. So maybe if you're going into Shoppers, and if you're going into somewhere else, if your friend has a blood pressure cuff, or if you even had heard that you may have high blood pressure, you go to Costco or any pharmacy and you buy a machine for $100. And if you get your doctor to write a prescription, it'll be paid for usually. Diabetes, type 1 means the kind that you're kind of born with early on. Type 2 is the kind later, associated more with overweight and other things. It also causes blockage of the small arteries. High cholesterol, or you may see the word dyslipidemia. They all cause this plumbing problem, which is also called, as you see the top left here, atherosclerosis. Cigarette smoking, it causes a blockage of large and small arteries. So for some reason, when I say this now to my patients in the clinic, sometimes I'll say, well, what do you think smoking actually causes? Now, most people, for instance, they often think about lung cancer. They don't think enough about blockage of the arteries. In high blood pressure, people think if they eat well and exercise, that they could avoid that and that it could help. But if you have high blood pressure and you have a family history of high blood pressure, it usually needs to be treated with some medication. Again, I'm giving you opinions and thoughts as if you're in my office now. Alcohol, too much alcohol is associated more with hemorrhage, maybe atherosclerosis, but the data is not there too much. So you just mentioned about that other guy, sleep apnea. You may need a CPAP machine, continuous positive airway pressure. People love it. They don't love using it, but they like the effect that it has on them. Sometimes after I just ask that question and no one thought of asking it, and they get there finally, they get their test, it's positive, get in the machine, and sometimes, I'm not saying everyone, but say 30, 40, 50%, people say, geez, I have so much more energy. I feel more energetic. I wake up in the morning, and because it's one of those insidious things that you're tired and you fall asleep in front of the TV and you have a drink and you don't really know that you have it, sleep apnea. Atrial fibrillation, there's a picture of a heart there. That's that when the heart has an abnormal rhythm. Very common. I have like 2 friends of mine, both family doctors in town, and they both have it. I'm giving you my performance of atrial fibrillation. because it's fun to do, because I started having like a video and it wasn't as good as this performance. So basically atrial fibrillation, in case anyone in the audience has it, a normal heart beats like this. Nice, even rhythm. And an atrial fibrillation heart beats irregular, like this. So just no rhythm, no rhythm. So what that does is it causes some clotting in your heart, because if it's pushed out fast, heart blood doesn't clot. If it kind of spins around, it forms little clots. And unfortunately, that clot could shoot up into your brain, block an artery, get a stroke. Young strokes, people, and then, people also have I'll bet you there's one person in the audience here that has what's called a hole in the heart or patent foraminal valley. And you can have that for 40 years. It doesn't mean you're going to get a stroke, but sometimes with other circumstances, it can cause a stroke. And then sometimes there's a few doctors in Ottawa, at the Ottawa Heart Institute, who may block it up. And that could help a lot. Young people could have other things like birth control pills could, even though so many people on birth control pills, it could lead to a stroke for thickening up the blood. They could have a heart that was a little abnormal from birth. They could have some unusual blood clotting problems. Say 40 and less. So on the right-hand corner is this brain that my son-in-law, his father, is I was going to say amateur artist. He's really an artist. I asked him to draw me some brains. So I'm using them in a few talks. His name is Victor Helfin. Thought this was his first trial of a colorful brain on the right. Oops, sorry. And so there's different things, even though we're looking at that brain there, that colored brain on the right, there's the right responsible for the left is responsible for the right. In other words, if the left brain gets a stroke, the right side will be weak. If the right side of the brain gets a stroke, the left side will be weak. But in spite of that, there's still certain things that are only on the left or only on the right. So for instance, if it's left, dominant hand, you'll have a language problem, whereas you have a stroke in the exact same place, you won't have a language problem if it's on the right. And then there's other things that you may not see things on the left. You'll get some weakness on the right. If the right brain has a stroke, sorry, that it must be on like autopilot. We'll have to change it later. So if the right brain has a stroke, then things are weird. People have some neglect of their left side. What does that mean? They sort of just don't pay attention. If one thing is happening only on the right, they'll be okay. But if something is happening on both times at once, they will ignore the left and just see the right. And there could be some weakness of the face and some loss of feeling also. So where are we talking about fitting in here? We're talking about me as a rehabilitation doctor, and then also integrating the community. In the beginning, we're trying to get people to not have a stroke. That's called the health promotion and risk factor management. If we could really get people to pay attention to their diabetes and cholesterol and all those things, they won't need the hospital. They won't need the acute care. That means the hospital like the Ottawa Hospital, Queensway, Carleton. And they won't need me and community integration. And then still after, we want to be very good at managing those risk factors that we just talked about. So after he goes to the hospital, Mr. Gnug, he's in the hospital, he gets care, and he's transferred to the stroke rehabilitation program. We're in Ottawa. It's Elisabeth Bruyere Hospital. That's why I'm in this office now. That's my background. We just did that for the first time ever. Is a poster that we made here talking about our stroke, and some of the same things that I just talked to you about, what they are and what part of the brain could cause the stroke person has. So in our hospital, we have a family doctor with an interest in stroke and a physiatrist, a stroke rehabilitation. That's me. And now some of my colleagues, because I'm doing more outpatient. So the bottom line is we can't just do rehabilitation, just a bunch of exercise, because people still have medical issues. They come sometimes after 5 days, 6 days, 2 days, 3 days. So at the same time, medical things are happening and rehabilitation things are happening. someone said, why don't you just say what a physiatrist is? Because also it means a specialist, just like you're a neurologist, you're a specialist in neurology. A physiatrist, the other word is you're a specialist in physical medicine rehabilitation. And someone wrote, it emphasizes the prevention, diagnosis, treatment, and rehabilitation of people disabled by disease, disorder, or injury. Not bad. So the first step in stroke rehab, I wanted to emphasize that we do that before to prevent the stroke, but then even after, because a lot of times people are coming in these days, partly with COVID, partly with neglect, partly with not having a family physician, big deal. So they're not on top of the stroke risk factor. So we use the stroke rehabilitation time as an opportunity to really get a hold of that. Now, this is something that I've been doing in the clinic the last year or something, diabetes mellitus. I just thought I'd share this with you. There's a thing called hemoglobin A1C. Like, again, if it was my clinic, I'd say, does anyone know what hemoglobin A1C is? But I think maybe we'll have questions after. We will have questions after. So hemoglobin A1C, this is how I tell it to my patients. Say in the old days, Mrs. Smith would come in, or Mr. Smith, and he had diabetes, and I'd say, how's your control, Mr. Smith? And if he wasn't marking it down, he would just say, oh, it's pretty good, it's okay, And I couldn't really tell if it was good or not. Maybe I could see if he had neuropathy, if he had numbness of his feet, but that's a little late. So some genius, I should look up, who invented this thing, said maybe we could do a blood test that would tell us how the blood sugar is being controlled over the past 3 months. It's unbelievable. So one test. So if Mr. Smith comes in now, we do this test in your family doctor's office. It's called hemoglobin A1C %. And that gives you the kind of control the person had of their blood sugar over the last 3 months. The key thing is not to think of the number as being a blood sugar number, which I say 50% of my patients think. They think that if you have a hemoglobin A1C, say, of 6.4, that means your blood sugars are being 6.4 all the time. That's not the case. 6.4 means your blood sugars are all the time about 8 or 9. So basically, they use this number to help people say to them, okay, you're fine. That's normal below 5.7%, 5.8%. Oh, for pre-diabetes, you're kind of in this range, Mr. Smith, that is 5.7 to 6.4. It's just like you could go either way. And then this will also tell us, like I get people who say, I've been good. I've been telling, and their number is 10. And 10 means your blood sugar has been constantly for the last 3 months about 15. That's crazy that they think that that's normal, but I get it. People, it's hard to control diabetes. You need education. Again, the family doctor may have retired, maybe all these reasons. And it's a chore to have diabetes. I say it's not easy to have diabetes. Same thing for hypertension. Initially, sometimes they don't treat that blood pressure right away, but in the rehabilitation unit, we will definitely treat it like within 2 weeks. You got to get that blood pressure down because that's what's causing some of the hardening of the arteries, that plumbing problems that we talked about. Sleep apnea, the patient may need a machine. And smoking cessation, we try to help, try to get people once they leave to go to classes if they can, go online. And I just threw this in, new smoking cessation, nicotine patches. Say, why? I've been asking people, why do you smoke? Because it's a question. It seems like, what do you mean, why do I smoke? I like it. So I think people do like it. And that's a good reason for me. And people will say it's a stress reliever, even though in medicine, they often teach us it's not a good stress reliever. So I say, who cares? My patients say that it is a stress reliever, that they're smoking to help them. So one concept is called, what hole in my soul am I filling with my cigarettes? And I write that down and I give it to the people. And here, this is I can't see it. So I'm holding a pack of cigarettes. And I'm holding it. That's the parking lot attendant actually in my hospital. We've become friendly. And one day he was talking about smoking. He said he liked to smoke, but he'd like to stop, and gave him that line, put it on his fridge. Took him about 6 months, and 6 months later, he handed me, this is a fresh pack of cigarettes that's cellophane on it. And he said, I really had to think a lot about it and wrote things down and thought about it. And here, I want to give you my last pack and keep it on my shelf here because it's kind of good and it's a good thing. Went home myself, and we do it for any addiction. Am I filling with my cocaine, my marijuana, my food, maybe, emotional eating. It's a nice thing if you're sharing with a friend, a colleague, a loved one, talk about it. Other medical problems that happen, so it's 10:31, perfect timing. So other medical problems post-stroke, just to remind you that it's just there's weakness, there's loss of feeling, there's swallowing, but we're going to go through some of these things. Just people get musculoskeletal problems like pain in their arms, because sometimes, as we see in the shoulder where the fingers are sticking in, there could be a little bit loss of strength, so the shoulder drifts down a bit. There's a thing called spasticity, in which the arm or leg will get tight. There's osteoarthritis, which you may have had before the stroke. Stroke doesn't cause osteoarthritis, but it could affect your stroke because if you have pain, then it may hurt when you're walking on a painful knee. And then there's peeing problems often, men and women, in which the bladder is, we call it a baby bladder, in the sense that you can't hold it in as well. And that does get better, but just knowing that that's what happens, the bladder's filling up and contracting, you don't have that ability, like you're in between the first and second period, to just wait, or at the end of the first period. So the bladder's kind of go. So what's the treatment of that? There are some medications, but then knowing that happens, you just go more often and all of a sudden you become continent. There's some unique things that stroke has that maybe skin cancer doesn't have, or arthritis of the shoulder. So people can have some swallowing trouble with stroke, just like muscles of the arm are weak, muscles of the throat can be weak. Fatigue. We're seeing this. It's so important. Dr. Christine Yang, who works with me, we did actually a paper on it, that it's just a huge thing. It's one of the biggest side effects. And just me saying that in a clinic, oh my God, I'm so tired, Dr. Finestone. Thanks for telling me. So at least they understand. And it does get better. It's the same thing with young people with concussions. Anything to the brain seems to cause fatigue. Short naps are good. Don't fight them. Emotional ability. What does that mean? It means that people do end up crying or laughing a little easier many times after stroke. Does get better also. Sometimes it stays a little. That just like I say, when does it happen? Oh, I'm talking on the phone to my child. I'm listening to a program on radio or watching, and all of a sudden I start crying. I mean, it's funny maybe, but it's more than I would have. Sometimes people note also that the side of the stroke is it just doesn't feel the same. It's not like they feel things, they can hold things, they can grab things, but for instance, its ability when they go into a cold environment, it seems to be colder, and they're more sensitive to heat and cold. So some of them, I put in some treatments. So like, for instance, the fatigue thing, people often, I don't know why, they often say, I don't want to take a nap. So fighting it, don't fight it. Take a short nap, 30 minutes to 45 minutes, not more than an hour. And that's really helpful. Nothing wrong with taking a nap in the morning, 1 a day, 2 a day, as long as it doesn't affect your nighttime sleep. You can't sleeping at night, so you're not going to, taking naps means you're taking away from some of that sleep. Hot and cold sensitivity in the arm. Sometimes an occupational therapist can help with that. They have certain baths, they have certain treatments that they could teach you about that. Of course, stroke and cognition, it's like hand in a glove. I mean, how could you get some injury to your brain and not have some deficits, some problems? Now, not all the time. Sometimes people get that kind of stroke, say with atrial fibrillation. We said it's a clot blocks up, and they use the drugs. Blood gets delivered quickly, so there could be not that much brain damage, and the brain is quite good in coping with a small amount. But for instance, we said the left brain, if it gets damaged, it could affect some parts of language. It's usually the temporal, parietal lobe. What's the difference? But interesting, I said that because it could affect reading, writing, speaking, and listening. Those are the main things of what language and communication is: reading, writing, speaking, listening. Yesterday, I had a patient, and she just had, I said, what do you really think that is a problem. She said, I seem to get the idea in my head, but I have to sort of like pantomime it or explain it, but I can't get sort of the word out. So we were looking at her CAT scan, and interestingly, she didn't have a big stroke of her brain. She had a stroke in the thalamus. And with the magic of, used to use other kind of educational things, but now even in the clinic, we'll sometimes use Google because Google is better than anything else. And we Googled thalamic, which is the part of the brain, which is a stroke called the thalamus. And lo and behold, when you get a small injury to the thalamus, you could get none of the typical signs of aphasia, and you can just have problems getting the word out and word retrieval. So that was an example of knowledge being at least helpful to the family. They said, okay, I get it now. Okay, I said, look, this is just like, it was just so perfect. So I didn't really change the aphasia. I think we're going to try to get her to speak more, because sometimes you could get things called neuroplasticity. You could, if you speak more, there's a reason to do speech-language pathology, because people get better because they use other parts of the brain that are not damaged next to the stroke to take over. Now, there's a thing called small vessel disease. I want everyone to really leave this talk knowing what this is. It means it's small vessels of the brain, not big ones, little, and you see on the MRI and CT, small little hits both sides of the brain. Microangiopathy, microvascular disease, small vessel disease, it's all the same word. This causes cognitive problems, and if you throw in a new stroke on top of this, so say you had this because your diabetes wasn't that well controlled, because that's what those stroke risk factors, if they're not controlled, they do. They cause this small vessel disease. Again, I'll be out of a business if there was loss of, if the people were controlling their blood pressure, their smoking, their diabetes, and high blood pressure, and cholesterol, we wouldn't even be here today probably. Small vessel disease, microangiopathy causes thinking problems from just impairment to dementia. And it's amazing. And people don't realize enough that probably it's neck and neck, maybe more, I think, sometimes than Alzheimer's disease as a major cause of dementia. And I'm seeing sometimes a 50-year-old guy, if he started smoking at 14 and he smoked till 50 and he has diabetes out of control, they get dementia. So then it could translate into other things like using the computer, texting. So these are things that you looking at your friend or a loved one with a stroke, or yourself saying, I'm forgetting passwords, it's getting tough. Those are some of the things that can happen with just small vessel disease, or with a new stroke, or with a new stroke and small vessel disease. So things like memory, concentration, planning, anything the brain does for us to think. So what do you do about that? Well, we want to encourage neuroplasticity. So I was trying to find a slide, a picture. So we found this the other day. The idea of like neuroplasticity. What is the definition? Is the brain, its ability to change, reorganize, or grow new networks by challenging it and repeating over and over the task they want to do. So the idea is this highway is closed. So to get straight from Montreal to Toronto, it's going to be tough, but there's lots of other paths to get there. So just like imagine, and I've thought of this example recently, just imagine that you're driving on the 401, 417, and it says detour, and you go off the road, and you go through a smaller town, smaller roads, and you get back on the highway. You still got back on the highway, but it took a little extra time and a little bit of maneuvering. That's what we want, that neuroplasticity. If we challenge the brain, if you, after this stroke, you continue to do things, you continue to talk, you continue to do games, puzzles, Wordle. There's a few, I didn't give commercial things, but there's things called Lumosity. There's some other, I think there could be beneficial to the brain. Just listening to the radio, we just pointed out here, and TV, it's not enough. TV, may challenge if there's some discussion and things going on, but radio could be just a lot of white noise. So what you're doing is you're actually creating all those pathways on the left, and it really happens. It's not a bunch of BS. It really happens, but it takes thousands of repetitions. Okay, so for instance, my patient who suddenly got quite good scores on some of the tests we did for cognitive, one of them is called MOCA coffee, Montreal, MO, C, cognitive, A, assessment. So he actually did better, like about 6 months after the stroke, and he wasn't doing that well. And I said, what are you doing? He said, well, I took your advice to heart and your team and the OT. And so now he used to be a pretty active guy, but now my kid has a restaurant. I go every day and I just set up the flowers, and then I do my gardening. Then I'm walking around the block. Then I used to play piano. We have an old piano in the house. I went back. So he's really stimulating his brain in multiple ways. And then he treated his stroke. Risk factors fundamental. Without the treating of the stroke risk factors, play piano all day. But it remarkably, and we saw it with a increased scoring on his points of his MOCA. So to me, like that sealed the deal about 5 years ago and saying, gotta pass this message around. So other things that, of course, can happen with stroke is mood, anxiety, depression. You may need some medications, you may not. Of course, this is where, friendships and your community, and your curling and your church are going to be fundamental. A lot of times people withdraw after stroke and they don't want people to see them that way. It's not the way to go. Remember, you're feeding your brain.
The poster, this is what it looks like.
Okay, just a second. I guess that must be from some other, okay, let's go back here. Okay, that's from a talk that I gave 2 weeks ago. I have no idea how that happened. Okay, so driving, often we must report the patient to the ministry who may be unfit to drive, and that's a horrible thing. We could talk about that after. We have a legal obligation in the province of Ontario, not in Alberta, not in Quebec, not in Nova Scotia, but in the province of Ontario, to report people. So if I see someone and they really are not doing well, and the family says they may have even scraped along the sidewalk and another car, we have to, or we lose our licenses. Sexuality, brought it in there because it's not like you can have sex after a stroke. You're on medications, you're on different things. Most of the times people are desire, they don't think they treat people fragile. They weren't having sex before necessarily. So the point is, we can ask a question, we can read about more. It's possible. So this is a stroke poster, and for some reason it's in there. So this is, we put that on the ward, and we've been showing that. We'll find out later why there's a talking behind it. So that's something though we could pass on to the people listening to this talk. So just 2 days ago, I put in this slide. I just woke up in the morning and I said, geez, how could I not give a talk? How could I give a talk about stroke and stroke rehabilitation without mentioning caregivers? I thought, oh my God. So luckily, the beauty of PowerPoint and finding information. I wanted to make a slide that was meaningful to me and things that I saw and I translate to my patient. There's a million caregiver slides and I went to a talk, but again, this is from the real clinic that's out there. So what do I see stroke patients, caregivers doing? So much. And I think it's hard to have a stroke alone and be alone with it. Going home, it's tough. Depends on, of course, the consequences, but it's going to be tough because the loved one, the friend has to help often navigate the medical and social system, and that's tough. Transportation, if they couldn't, drive because they had some loss of vision on one side, it's both eyes, both sides, that's called visual field deficit, or they're weak, or they have some confusion, they need transportation. And they may need patients to look up their test results on my chart. And even that is hard for people who don't have a stroke. They may need to arrange appointments. I want to write a paper now, and we're actually writing down a bunch of these things on appointments in the stroke clinic. Like people miss appointments, people miss at the time. They show up on Wednesday at 2:30 and they say, you gave me an appointment at Wednesday 2:30. Jane, never have a clinic at Wednesday 2:30. Things get mixed up. And so arranging that, answering telephones, that's where sometimes that caregiver, that friend is so fundamental, makes the emotional support if the person's down. So this is probably somewhere in some official slide. This is my slide. And then I was thinking, because I've been to talks about caregiver and I met some people, so I just did a little search. There is an Ontario Caregiver Association. I looked for Ottawa, but they mainly gave lots of resources under caregiver, and they didn't have as far as I know. If anyone in the audience after will tell me, didn't seem to have an Ottawa caregiver. They had within the Dementia Society, which I highly regard, there is some coaches and definite navigators. But overall, they didn't have like an overall thing called the Ottawa caregiver, as far as I can see, if anyone knows. So there's an Ontario caregiver, and then I went to a wonderful talk at the World Stroke Congress about 6 months ago, and someone from it used to be called the Bridgepoint, but now I think it's called the Hennick Bridgepoint Hospital, part of Sinai Hospital Health, and they have really done a lot of amazing work. And they actually, so much so that they set up a Siren Caregiver Resource Center, which is available to anyone. So if anyone out here is providing care to the level one stuff, and they feel that there may be more information they want, I think you could go. I know you can go in there and look and get some more information. So we'll just do 3 minutes on this, and then we'll wrap it up. So we are 2 minutes over. Okay, so I just thought for fun, this is something that I've been doing, but I didn't do it in this formal way. And I just thought it's fun. And so we're doing it. So I just thought I kept on, maybe MTO is on my brain. And so, and people seem to know MTO. So maintenance of transitions. So I thought, okay, you forget things. So, this is the story. The story is someone is 68 years old. He likes to go swimming, or she goes to the garage. Goes to the guy and says, oh, I've got my keys. I've got my gym bag. They go up in the house to pick up the keys, they head back to the car, and then they say, oh, my swim pass. So, okay, this is not dementia necessarily from stroke. This is just perhaps some, but likely not, just a familiar story that when I've now told this to over 100 people to say, is this familiar? Because I'm preparing for this talk. And they said, oh my God, familiar. Okay, so what are we talking about? We're saying, as we age, even if we're young and distracted, we forget things. Small stroke happens. There could be small vessels. That could be more. So is there a system? So we looked up online, and you go on Google Images, and you get nice pictures. So here's like little stickies. Maybe this is my desk, but I don't think so. Close. So could we have a system that I'm sure everyone has their eyes, wallet, pocket? So anyways, we designed this thing called maintenance of transitions. I've been doing it pretty religiously for the last 3 months in preparing for the talk, not preparing, but, so it's sort of like, how do you, when you're leaving the house, what to think about? And you'll let me know. So, basically you ask yourself, where am I going? What do I need? And what special actions do I take? So I specifically put it towards the swimming guy, which is me. So I got to say, okay, where am I going? I'm going to the office now. I'm going to the swimming pool, garage, Canadian Tire. Okay, for Canadian Tire, I need my, so then you think of each thing. For Canadian Tire, I need my bill because I'm returning something. In the garage, I need to have my keys. And then we purposely put spirals, because the idea is they're not unique, these 3 categories. They keep on looping on each other. So so by asking the questions, and you don't leave the house without asking the 3 questions. MTO, maintenance of transitions. You don't have to remember that. Where am I going? What do I need? What special actions do I take? So what do I need? Okay, what do I need to go to the swimming? What do I need to go to my office? What do I need to go to Canadian Tire? So there's a lot of same things. And then we were thinking, I actually surveyed even the employees of the plant pool, so they should get some credit on the bottom of the thing. There's always something special or unique. So in the pool, for instance, you have a locker, you have your lock, you have goggles, you have flip-flops, and they're not in where am I going, what do I need? So that's where even when I'm at the locker, I'm saying, okay, now I'm going to the pool. Okay, I need to pull out my locker. So anyways, the idea is, where am I going? What do I need? What special actions do I take? And we do this before we go from the house, when we're moving from one place to another, when we're making a transition. And so I asked them, do they have any examples? And this is, I think, 1 week old or 2 weeks old. People not using they're not using this technique. So this is how many, I think in a couple of weeks or something, how many goggles are forgotten, and this is in the lost and found, and how many locks are left on the on the locker or back in the, look, that's only April 23rd. So that's not far along. So and they get rid of them once they put a piece of tape, they put the tape. Okay. So that I thought that was hilarious, and so that's that little added thing. So in summary, a stroke is a problem with circulation to the brain. Stroke risk factors are the critical things: blood pressure, diabetes, cholesterol, smoking, atrial fibrillation, obesity, sleep apnea, and other stuff. If you had a stroke, the goal is to develop neuroplasticity by repeating the things that are important over and over and over again, so that the brain remodels itself. You got emotional healing, acceptance, physical rehabilitation, and that's it. Thank you.
Hey, Dr. Finestone, thank you so much. Now we'll go to the Q's and A's, and I will read you the questions.
Perfect.
This question is from Karen Hill. Does research on females show the same causes, symptoms, and treatment?
So recently, the Heart and Stroke had, when they had the Heart and Stroke Day, once a year, they actually asked me to speak about females. So there's certain things that maybe stress and emotions, and actually that's a mistake. Stress and emotions are actually a stroke risk factor. So the research on women in, for instance, heart medicine is that often women don't get taken seriously for their symptoms enough, like if they have heart disease. But in general, still, those risk factors are the same. Maybe though, again, if they're not taken seriously enough, smoking is still huge, and women seem to be increasing in cigarette smoking sometimes lately. The stress and anxiety component, maybe with stress it being a risk factor, that it's maybe there's some studies that show that women with their responsibilities and caregiving and other factors, they may have some increased amounts of stress. But overall, there's the birth control pill, that may be, but overall still, if we would stay to the basic stuff, that it's still similarities. But yeah, I'll just leave it like that for now.
Okay, the next question from Louise Klein. Mom lost most of the use of her left arm and leg after her stroke in 2020. Does that indicate a right brain stroke?
Yes, so that's pretty very, very clear. Right brain, left side causes weakness or loss of feeling. Right? So left brain, the opposite side is
Okay.
weak. Yes.
I'd just like to invite people, if they've got questions, to put them in the Q&A, and I'll continue with the next question. From Gord Doonan. How do you access some of these treatments, for example, occupational therapist, if you don't have a doctor to give you a referral?
Exactly. So this is the biggest problem in our society right now. So first of all, OTs are hard to come by in private medicine, in the day-to-day practice. PTs, physiotherapists, we all know about, they're there. You have occupational therapists, there's not the same kind of network of occupational therapists out in the clinic. So if you had a stroke and it's like over a year, you're often out of luck in getting an OT. If you're within the year and you had a recent stroke, you're going to get OT like through our clinic, like through we have a stroke rehabilitation outpatient clinic at Elisabeth Bruyere Hospital, or you're going to get it like if you're leaving the hospital, you're going to get an occupational therapist as part of the community stroke rehabilitation program. But you're right. So you can, though, so if you guys do have, federal retirements often have some insurance and you have some money, so they're not like millions of dollars. So there are some occupational therapists in private practice. If you got your family doctor to write a script to say that, say hand post-stroke, weakness, please assess and treat, then you can get an occupational therapist. They do exist. Probably costs $150 to $200 an hour, but maybe 2-3 sessions at least to get you going again. That could be.
Okay. Another question from an anonymous attendee. My friend, 48 years old, died suddenly. The coroner indicated it was a brain hemorrhage from untreated high blood pressure. Is this the same type of brain hemorrhage that would cause a stroke, except on a larger scale?
No, so this is a great question. This is a stroke. Untreated high blood pressure, you don't feel it. Some people say, I know when my blood pressure is high. They don't. They may know when it's crazy high that they're getting headaches or some visual problems, but that's when it's like so high that it's unbelievably dangerous. But the bottom line is every day Your blood pressure is high, you don't feel it. Your heart is beating harder because it has to beat against a higher pressure. So just like a pump beating against, say, a smaller pipe, it has to exert more pressure, and then the heart becomes fatter and it gets enlarged, and it could get a stroke that way. But also the blood vessels in the brain, they're good in maintaining high blood pressure. Like, in other words, when the high, say you suddenly there was high pressure in plumbing of the house, most of the time there's not a leak. Pressure maybe could go for a couple of years, and then suddenly the one tap underneath the sink goes. That's what happened to this person. The high pressure, blood pressure wasn't treated. They became at the places where there's branching, often that area is a weak spot that if blood pressure is hitting it all the time, high blood pressure, then it causes some weakness, and eventually it could go 58, 48, 38. 48 is a pretty classic time for untreated high blood pressure that went. It could be a small, one of those smaller blood vessels, and the wall became weaker and weaker and weaker with the high blood pressure, and until finally it opened up and got a brain hemorrhage. And that's what happened to this person. Chances are.
Okay. Dr. Finestone, we have a few more questions, but we're really close to 11 o'clock. Would you be able to stay on
Yeah, we could go a few,
a few minutes? Okay, thank you. Much appreciated, because the questions are really interesting. Another one is, can neuroplasticity improve peripheral vision loss after a stroke?
Fantastic question. Not as good an answer. If it's a severe visual field loss, and I'm still learning myself, even as I age myself, severe visual field loss, say a couple years later, there's not a lot of good evidence that neuroplasticity happens enough, for instance, to get it back, to say, get back driving. I still think that visual fields, it's possible that you could develop some neuroplasticity with some people having the treatments. You can look them up sometimes for visual field testing. Sometimes they even just say, you know, when you're looking at the TV, look at the top right of the picture and then look to the left. But overall, it's not fantastic. It's not as good as, say, some neuroplasticity to help your cognition. I wish I could say it was, but I can't.
Okay. From B. Brock, is a stroke the only cause of short intermittent double vision?
Oh, no. I mean, there's the other word for double vision is diplopia. Little tidbit that you can't have double vision with one eye. So if you close the eye and you still have double vision, then got to think of something different. And there's lots of things that cause double vision. So it's a common cause in stroke and in people who are getting older. But, you know, you got to check your eye doctor, because sometimes you can have a weakness of a muscle. There are some other neurological diseases, or like, say, nerves, that could cause double vision diplopia. So not the only cause, no.
Okay. Another question is from Jagid Kosla. I had a branch retina vein occlusion in left eye. Could it be a microvessel stroke?
Yeah, so a branch vessel, so there's a thing called central retinal artery occlusion, CRAO, which is, I was going to use the word crappy. It's a bad thing. It's not a good thing, in the sense that basically it's a small vessel, and it's a vessel that blocks just to the eye, and you can cause some degree of blindness, either complete blindness of the eye, or if she had a branch vessel, less. So it definitely could be caused by a little embolus, say from the heart, or a clot from somewhere else, like, say, either from the neck or from the heart. It could be caused by the same reasons of the risk factors, like the atherosclerosis, just blocking off a small branch, and cause that problem that you mentioned.
Okay. Another question is, what is the risk for a stroke if one has a left para-ophthalmic aneurysm measuring 3.5 millimeters?
I'm sure someone better than me has been asked that question, and like the neurosurgeon or the eye doctor. I mean, an aneurysm. It is a risk, but they will tell you what they think. Why don't we ask that person what they've been told? Because yeah, there's no way of giving an answer to that question really. But you know, sometimes they have experience. They say once it gets to a certain level, then it's a higher risk of having, and you know, and then they often watch it up to a certain level. That's probably what they said to this person.
Okay, and then here's another question that says the previous question was how to access an occupation, an OT, if one does not have a family doctor. So I guess that you answered that question.
Yeah, so you got to get someone to be able to, you know, maybe you could even go to a walk-in clinic, or maybe look at some of the is there yeah, a walk-in clinic could do it. It's crazy to have to ask that question, but what can I say? Yeah, I think, you know, if you want to write down and say diagnosis equals stroke, requesting occupational therapist to help better manage stroke's effects. So that would be what the person could write it themselves and ask the doctor to sign it. I don't think any doctor would feel bad about signing that. It's not like they're asking for opioid medication. Is there a nurse practitioner program? Look around to see who could give you a prescription.
Okay. And another one is for about 5 years, this person has noticed discomfort in their legs when they wake up at night or in the morning. The masseuse says they have a very high muscle tone. Could this be a sign of a mini stroke, or how can this be alleviated?
Okay, so that's not a question really for today. We don't have enough information, but I would say that muscle soreness waking up in the morning is not, in general, is not a sign of stroke, specifically if it's both legs. It's probably not, but you know, that's something that would have to be looked at by the doctor and ask them. But yeah, in general, not. In general, not.
Okay. And then another one is, what is the best equipment to measure blood pressure?
The best equipment is one of the machines that you could get that says, you know, they all say it, but it says certified by the American or Canadian Heart and Stroke Foundation or something like that. So that's why even like, you know, Omron, OMRON is often seen, like obviously the ones at Costco, but I don't want to say Costco, you know, I do go frequently into to drugstores to see do they have, and most of them have. You don't have to get the fanciest one. If you just mark down yourself on a piece of paper, that may be enough. A lot of them have, you know, the fancier it gets, they get, you know, connected to your Wi-Fi. You know, some people like that, connected to your phone, so you can get a list of the values. The key thing, okay, this is good. The key thing is that what I'll often say is, if you just go once to your doctor and you haven't seen him for a while or her for a while, and you give one blood pressure, sometimes what happens is that the doctor will say, okay, it's a little high, we'll see, take the blood pressure. So if you could go into your blood pressure, into your doctor, with say, minimum of 3 weeks of daily blood pressures, you're gonna be laughing. What does that mean? It means, so you take your blood pressure, you get the machine that's certified, you buy $100, $200. If you get a prescription, sometimes it's covered. And then you mark down those blood pressures, or you have a tape, part of the machine, you know, prints them out. Take it every time in the morning. Say it has to be, you know, you have to look at the recommendations. 15 minutes of rest, sitting down, same arm, no coffee. And you take that in the morning. So if you could bring in 3 weeks worth, and the doctor could say, let's look at these numbers. And the bottom line is about, say, 5 days out of the 3 weeks, if there's more than 140 over 90 in a person without diabetes, or greater than 130 over 90 in a person with diabetes, you need to be treated. You need medication. But you're not going to get that, because half the time you're only coming in, you're only getting that one blood pressure. And then people say, oh, I have white coat syndrome. Yeah, maybe, but I think we're overcalling the white coat syndrome. And so get the blood. And if you really wanted to do well, what I would do for me is I take it at one time in the morning, and then I take one more time during the day, either lunch, supper, bedtime. So the person had 2 values every day, once always in the morning, as we sort of traditionally, and one other time. And then I think you could really make a one-time decision with that.
Great, thank you. That's it for the questions, but we do have some comments, and we've got people who really found the session very informative and appreciate this a lot. And they particularly like the fact that we are learning what to do to prevent strokes and when we have it, and then also acknowledging the role of the caregiver. So that is quite something that is appreciated. Now we just got one more question, so I'll go
Okay.
with that question. I'll ask
Go
it.
for it.
Okay, whenever I go to the doctor, my measured blood pressure is high, but when I do it at home, it appears normal. Is this acceptable, or should I do a 24-hour monitor?
So that's, I think, a great question. I just had a long discussion with a person about that recently. So my thoughts often, I think the person should take the blood pressure, then take it other times during the day. Is it possible that it's only in the doctor's office that it's elevated and nowhere else? My thought is not so likely. I think blood pressure is blood pressure. So it's in that time that the person is taking the blood pressure in the office, it's a real blood pressure. It's not a fake blood pressure. It may be elevated only because the person's nervous or tense, but it's a real blood pressure. So if that similar blood pressure is happening, if the person is having an argument with their wife, if they're at a store and they're giving back something, and it's happening repeatedly during the day, then I don't really care that it's just either white coat or some other reason. It's still real blood pressure affecting the blood vessels of the heart and the neck. So the answer is, if this person could prove to me that it's only in the doctor's office, which I don't think it's probably likely, but it's still possible, then okay. If that's one time out of 1 minute or 5 minutes out of 3 other hours, okay. But so think of it in that way. Chances are there's other situations that it's happening. Take your blood pressure, for instance, maybe when you're upset, take your blood pressure at other times during the day. I think you'll probably find out that your blood pressure is elevated, and that means you need medication.
Okay, thank you. Now, there is one last question, and I know I had said the last question, but this one intrigues me.
Okay.
So, is a cerebellum stroke capable of recovery?
So a cerebellum, again, it's like the picture, it's in the back behind me, there's a few brains, and we obviously couldn't give like every part, but cerebellum is a specific part of the brain. It's in the back of the brain, and for instance, it's the only one that doesn't follow that rule that we talked about, that the right brain causes left-sided symptoms, and the left brain causes right. The cerebellum is the only one, for some reason, it sticks to its same side. Okay, that's one thing. Cerebellum is the guy that I call the smoother outer. It doesn't cause weakness if you have a stroke in it. It doesn't cause loss of feeling, but it smooths out all our movements. So instead of reaching forward and straight like that, the person reaches kind of like this. It is a coordinator of our voice, of our limbs, of our movement, of our walking. So someone who has a bad cerebellar stroke, they could be shaking, they could be walking funny. So does it recover? Yeah, it does recover, actually. Like cerebellar hemorrhages recover quite well. Cerebellar strokes, most of the time, when I examine them, say 3 months later or a year later, a lot of times the person had a cerebral stroke, but I don't find it very strong later. So that must mean that there is some compensation and some neuroplasticity going on. I don't know if there's a paper on that, and maybe it would be nice if the person listening, if they could share with us, have they gotten better? Are they continuing to get better? If they want to talk, you could just unmute yourself and speak.
Well, actually, we can ask them to probably put that in the follow-up email where they could ask directly the question.
Well, we're asking them a question. We're saying,
You're asking them a question.
have you improved? But it's a good question, because yeah, there's certain parts of the brain that seem to recover a little better. And cerebellum, I must say, if it's not a big thing, I've seen many cases, they said, oh, the cerebellum's affected, and I see them say 3 months later, and it's not that bad.
Okay. So I'm not sure how this would happen. Let me see, either in the chat. I'll check to see if there's anything in the Q&A.
Yeah, and then my voice
There's
is
nothing
going.
more in the Q&A. And So that's it.
Okay,
So thank you, everyone, for your participation in today's webinar. And on behalf of the Ottawa branch of the National Association of Federal Retirees, thank you, Dr. Finestone, for this informative and very helpful presentation. So for everyone, remember to look for our follow-up email, and it'll include information on how to access the recording of today's presentation, as well as contact information for our presenter. Remember that you can invite non-members to attend our sessions and try as a guest. To register for upcoming webinars, we invite you to visit the Ottawa branch website at nafrottawa.com. Thank you, everyone, and we hope to see you next week at our in-person fitness class with Meg Stickle. Croker.